Hello everyone, and today we will continue what we have begun with yesterday and every day, the lower respiratory tract and its role in ventilation. In this figure, right and left lung, we see the pulmonary arteries, bronchus, bronchial arteries and veins, bronchi, and the pulmonary veins, the roots of the lung. Pulmonary vessels and nerves. Blood supply. It is important to realize that there are two blood supplies to each lung. The most obvious vessels are the pulmonary arteries, which are branches of the pulmonary trunk carrying deoxygenated blood from the right ventricle of the heart, and pulmonary veins returning oxygenated blood into the left atrium. The alveoli receives oxygen and nutrients as gaseous exchange between blood and air occurs through their walls. The bronchi and the bronchioles, connective tissue and visceral pleura, receive oxygenated blood from the much smaller bronchial arteries or bronchial arteries, which arise from the descending thoracic aorta. Anastomosis between these systems become important when either is occluded by a disease. The effects of blockage of pulmonary arteries are described. Lymphatic drainage. Lymph drainage follows the bronchi and pulmonary vessels to the lung roots. There are many lymph nodes in the trachea bifurcation. If you have the opportunity to dissect the thorax, you may be able to identify these nodes because they are usually stained black or by atmospheric pollution, even in non-smokers and country dwellers. Again, the lymphatic drainage follows the bronchi and pulmonary vessels to the lung root. There are many lymph nodes in the tracheal bifurcation. If you have the opportunity to dissect the thorax, you may be able to identify these nodes because they are usually stained black by atmospheric pollution. Even in non-smokers and country dwellers, the spread of lung cancer through the lymphatic drainage is described. Pulmonary embolism or pulmonary thromboembolism is due to the transport of a blood clot to the lung through the right ventricle and pulmonary arteries. The clot usually originates from a distant site such as deep leg vein. A large clot can be fatal and a small one may cause damage to the bronchopulmonary segment by blocking its artery. Lung cancer. Carcinoma of the bronchus is one of the most common forms of cancer in developed countries. The predisposing factors is tobacco smoking, and now lung cancer is increasing in incidence in developing countries as tobacco products become more available. Lung cancer is not easy to detect in early stages. By the time the cancer is diagnosed, the prognosis is generally poor because it has often metastasized extensively. The lymphatic drainage of the lung facilitates its spread to the pleura and to lymph nodes at the hilus of the lung and in the mediastinum. Metastasis within these lymph nodes soon spread to more distant organs, especially the vertebral column and brain. Supply, next subject. The lungs receive an autonomic nerve supply through the pulmonary plexus, comprising branches from the sympathetic trunk and the parasympathetic branches from the vagus nerves. Sympathetic activity produces bronchodilation and parasympathetic produces bronchoconstriction. Sensory nerves from stretch receptors in the bronchi and alveolar walls are important in the reflex regulation of the degree of the lung inflation. Over 50% of these receptors are in the bronchial tree within the lungs, and the rest are located in the trachea and main bronchi outside the lungs. Despite their name of stretch receptors, they respond to pressure differences across the walls rather than physical stretching of the walls of the lower respiratory tract. As the pressure changes during ventilation, stretch receptors are stimulated and inhibit contraction of the muscles of inspiration in the respiratory centers in the medulla, allowing expiration through passive elastic recoil. Box number 11. Asthma. Bronchial asthma is due to spasm of smooth muscle in the bronchial walls, which results in bronchoconstriction accompanied by thick mucus secretion. Asthma is a restrictive lung disease. Patients have more difficulty emptying the lungs than filling them. It causes wheezing and difficulty breathing, and victims often fight for breath. It is a major problem in developed countries and has multiple causes, including allergies to inhaled or ingested substances. This subject is about the mechanisms of ventilation. Respiration is the term commonly used to cover breathing, but it should really be more accurately called ventilation. Respiration strictly relates to the exchange of oxygen and carbon dioxide between air and blood through the alveolar walls and blood and tissue through capillary walls throughout the body. Many of the fundamentals of ventilation are known, but some of the detailed movement is still not completely understood. Thoracic volume must be increased, leading to a drop in pressure within the lungs. For air to move into the lungs from outside the body, the air is drawn in by the reduced pressure in the lungs, aided by the greater atmospheric pressure outside the body. The increase in volume during inspiration has two main components: an increase in vertical height of the thoracic cavity produced by movement of the diaphragm, and an increase in diameter of the anterior, posterior, and lateral axes by movement of the ribs and sternum, produced by the intercostal muscles. In babies and young children, respiration is entirely diaphragmatic, as the ribs lie almost horizontally and have not yet acquired their familiar down-curved shape. Adult men are said to move their ribs less than women and therefore rely more on diaphragmatic movements. Ventilation rates and depth are matched to the demands of the body. Another example of hemostasis. Quiet ventilation takes place when we are relatively inactive, such as sitting down reading. Forced ventilation occurs in response to exercise. Ventilation tends to be rhythmic. The inspiratory and expiratory phases of each breath take about the same length of time, irrespective of whether we are breathing slowly during quiet ventilation or much rapidly during forced ventilation. Ventilation is under the control of the somatic nervous system, not under the aegis of the autonomic nervous system. So, is a voluntary activity. However, ventilation is too important to be left to chance, so is controlled automatically in most circumstances. The main drivers of ventilation are the levels of oxygen and carbon dioxide in the blood and the cerebrospinal fluid. These levels are monitored through the chemoreceptors in the arterial circulation that send signals to the respiratory and cardiovascular centers in the medulla of the brain. The respiratory centers will increase ventilation if there is not enough oxygen in the blood. Likewise, ventilation will be increased if too much carbon dioxide accumulates. The automatic control of ventilation can be overridden. Holding your breath is the simplest example. But if you forget to breathe out, your body will override your actions and make you breathe again. When carbon dioxide reaches dangerous levels, breathing during speech is another example of overriding automatic rhythmical ventilation. Now moving to the next subject, quiet ventilation. Of course, we have a quiet ventilation, forced ventilation, and within quiet ventilation, we have a quiet inspiration, quiet expiration, forced inspiration, forced expiration, etc. Focusing now on quiet inspiration, and later in other lectures and reading episodes, we will focus on the other subjects of quiet and forced ventilation. In quiet inspiration, the muscle fibers of the diaphragm contract. In quiet inspiration, their action is to pull the central tendon downwards since they are firmly anchored peripherally. This movement increases the vertical dimension and decreases pressure within the thoracic cavity. The abdominal viscera are pushed down as the diaphragm contracts. At the same time, the first rib is fixed by the scalene muscles in the neck, and the upper intercostal muscles are active. Comparatively, little movement of the upper ribs occurs, but the sternum is displaced anteriorly, increasing the anterior-posterior diameter of the thorax. The sternum is moved forwards and upwards during inspiration because of the obliquity of the ribs attached to it. The lower ribs pivot at their posterior and anterior attachments and swing out, increasing the lateral dimensions of the thorax. The middle ribs are able to move laterally because of the flexibility of the long inclined costal cartilage, which the middle ribs are able to move laterally because of the flexibility of the long inclined costal cartilage, which connect them to the sternum. The costal angle between the costal cartilage of the lower ribs on each side increases appreciably during deep inspiration. In quiet ventilation, about 75% of the increase in thoracic volume is produced by the movement of the diaphragm and only 25% of rib movements. The movements of the chest wall during ventilation are followed by the lungs, which therefore expand, drawing air in, or contract, force air out. The pleural layers play an important part in this process. The parietal pleura will follow the movements of the thoracic wall as they are directly attached to it. In visceral pleura, or the visceral pleura, will follow the movement of the parietal pleura because of the adhesion of the two layers brought about by the thin layer of the pleural fluid between them. Pleural fluid has the same effect on the pleura as a thin film of fluid between a glass and a wet table. The glass may slide easily along the table but can only be raised away from the table by using considerable force. The pleural fluid enables the pleural layers to slide over each other wherever they are in contact, and also to resist the opposite forces generated by the movement of the chest wall and the elasticity of the lungs. The lungs will inflate because of the visceral pleura are attached directly to the lungs.